Hi, thank you so much for asking me to talk, Atul. And as said, my name is Katherine Harmon, and I'm one of the paediatric respiratory doctors at King's College Hospital, London. The title of my talk is New Technologies in Sleep Medicine. However, whilst I was writing it, it changed very slightly to be the interaction between technologies and sleep medicine. So we know that technology advances rapidly, and it's well known in Silicon Valley, Moore's law, that states that the number of transistors on a microchip doubles every 2 years. It's well stated that mobile phones, have more computing power than Apollo 11, the rocket that first made it to the moon. And medical knowledge advances rapidly as well, with 50% of medical knowledge changing every 5 years. Technology and medicine has progressed hand in hand, and I've listed some of the common resources of this here. Many of these are relevant to pediatric respiratory medicine, particularly precision medicine, where physicians treat individuals based on genetic makeup, and this is relevant for cystic fibrosis and the new small modulator therapy. Electronic monitoring devices such as smart inhalers, where we monitor adherence to patients with asthma, and telehealth and health wearables. The last two of these in particular require what we call the pocket rocket, the mobile phone, in a new branch of medicine known as mobile health. So mobile health is described as the application of sensors, apps, social media, and location tracking to obtain data pertinent to well-being and disease. Mobile health is a very appealing prospect, particularly for chronic disease, and it's estimated that approximately 70% of the US health expenditure is on chronic disease. Mobile health is also particularly accessible, with over 80% of adults in the US owning a smartphone. As smartphones are always in constant use due to messaging, internet access, GPS, games, so people always have a mobile phone on them. I find mobile health particularly relevant given the current situation with the COVID-19 pandemic. We were planning to meet in Bush House in person. However, instead, most people are accessing this either through a mobile phone or through a device that they've got at home. In the last few weeks, we've all signed up to apps that we'd never heard of previously, and we've attended virtual meetings with the MDT to reduce our interactions with each other. We've all also joined webinars so that we could learn more about COVID-19 with the rapidly advancing information. And we've even changed the way that we contact our patients using teleclinics in the last few weeks in ways that we've never done previously. However, despite the growing presence of mobile phones in society and health, it's still entirely unclear whether there's overall benefit or harm. And in view of this, I decided that I would write my talk about the complex interactions between mobile phones and health, but particularly focusing on sleep and sleep medicine. First of all, I'll talk about the effect of mobile phones on children's sleep, and then move on to talk about the advancing field of mobile phone sleep apps for monitoring sleep and where we use them clinically. And finally, I'll talk about smartphones and telehealth, which we've all become much more accustomed to. So first of all, the effect of mobile phones on children's sleep. Due to the current necessity of social distancing, children are much more reliant on their phones than they have been ever before. They provide a huge number of beneficial applications. I've put some pictures of some here, such as e-learning, mental health apps to help people with anxiety during social isolation, staying in contact with their friends, and also fitness on their apps and on their mobile phones. So in total, phones do bring a number of positive influences for children. However, they do have a negative effect on sleep, and it's essential during this period not to forget sleep hygiene for children. So what's the extent of the problem? Sleep deprivation is estimated in at least 30% of preschool children, and between 50 and 90% of school-age children do not get the recommended amount of sleep. There's also been a huge increase in the access to mobile phones, with over a 5-fold increase in children's access between 2011 and 2013. By 5th grade, approximately 50% of children have phones, and over 60% of these keep their phone with them at bedtime, with data showing that 1 in 12 are woken up by a text message at least once or twice a week. There are 3 proposed mechanisms by which electronic use could cause sleep disturbance. This is psychological stimulation based on the media content, time displacement, and this essentially just means if you go to bed an hour later because you've been playing on your phone, but you have a set wake-up time, then you're going to lose fundamentally an hour's sleep. And also the effects of light emitted from devices on circadian timing, sleep physiology, and alertness via melatonin hormone. So if we look at the first two together, psychological stimulation and time displacement. There's a large systematic review published in Sleep Medicine 2015, which looked at 67 studies looking at screen time, looking at TV, computers and phones, and looking at sleep outcomes in teenagers. The results were conclusive, with over 90% of them finding that screen time was adversely associated with sleep health, primarily with delayed bedtimes and reduced sleep duration. Of those looking specifically at mobile phones, the evidence was also very conclusive. 15 out of the 18 studies found a negative association between mobile phone use and at least one sleep outcome. 10 of the 12 looking at total sleep time or delayed bedtime found a difference ranging between 20 and 45 minutes. The single study which investigated mobile phone use and sleep quality found a negative association, and all 5 which investigated phone use and the assessment of daytime tiredness found a negative correlation. Of interest, computer and phone use consistently associated with poorer sleep outcomes than television watching. And that's possibly because watching TV is less interactive than playing on your computers and phones. This is nicely illustrated in the study by Fuller et al. In 2017, who looked at 234 children. You can see here that the devices listed at the bottom, TV, phone, video games, and computer. Those that played with them were in the grey bars and those that didn't within the black bars. That there was an overall reduction in the hours of sleep throughout all the devices. However, if you look at the chart on the right and look at the likelihood of being tired in the morning, whilst all of them were associated with increased tiredness in the morning, television at the bottom was least likely to be associated with being tired in the morning. It's also thought that this may be age dependent, as adults screen time was associated with sleep onset latency, however, not tiredness in the morning. And this may be due to the ability of adults to be able to compensate by sleeping longer and having more control over their wake-up time. There are some limitations to these studies. They're based on cross-sectional, observational, and self-reported data, and causal association is not confirmed. There's also measurement error, both in the screen time exposure and with sleep measures. And there is limited data on the multiple screens, characteristics, and on content of screens used. However, the data that we have to date is fairly conclusive. The other effect of mobile phones on children's sleep is due to the effect of the light emitted from the devices on circadian timing, sleep physiology, and alertness via the hormone melatonin. We've all heard of melatonin, and it's the hormone that regulates sleep-wake cycle. It's commonly used for people who have jet lag and night shifts and sleep disorders, and some of our international viewers may be relying on melatonin now to stay awake to listen to this. The hormone is the highest between midnight and 8 o'clock in the morning, and there's delayed release in teenagers, which is why they often sleep later and wake later, and production decreases in old age. Melatonin is suppressed by light, and in dark, the suppression is disinhibited and melatonin is secreted. You can see that in the diagram here. There are photosensitive ganglion at the back of the eye, which detect light. They send signals to the suprachiasmatic nucleus, which inhibits the pineal gland from releasing melatonin. In the absence of light, the pineal gland is disinhibited and melatonin is released. It acts on melatonin receptors throughout the central nervous system to make you feel sleepy and tired. Blue light in the 450 nanometer range is more effective at suppressing melatonin levels than light in other ranges. And this is relevant because devices emit light in the blue light range most frequently. And of interest, children appear to be more sensitive to this light melatonin suppression than adults do. And it's thought this is due to age-related ophthalmological features, such as larger pupil size and children having an increased light transmission rate of the lens, particularly in the blue light range. This was a study performed looking at children and adults, and you can see from the bar chart on the left that both in dim light and bright light, children do have larger pupil diameter than adults. When they're exposed to a light stimulus, in both light conditions, dim and normal light, in the hours before bedtime, children had melatonin suppression was twice that of adults. These results have also been replicated in adolescents. And what's the effect of melatonin suppression? So in the short term, it affects sleep. It shifts the circadian clock to the right, as can be seen in this diagram with the red dotted line, and delays the time that you actually fall to sleep. As we mostly have set wake-up times, this ultimately reduces the number of hours that we spend asleep. It also reduces the total amount of REM sleep. And you can see this by looking at the hypnogram. This is a hypnogram of a normal subject going to bed at 10 o'clock in the evening and waking up at 6 in the morning. The black lines indicate normal different stages of sleep, whereas the red is REM sleep. If you shift the sleep forward by an hour, as REM is the final part of the sleep, you end up missing out on that large proportion of REM sleep. And that means when you wake up in the morning, you don't feel as alert as you would do if you'd had the full night's sleep. I had a look to see whether night shift mode makes a difference. Night shift mode was an app that was released by Apple in 2016, and it puts your phone into a mode which reduces the amount of blue light and has increased warm colors over your screen, with the hope that it reduces your melatonin suppression more. There isn't much data about it, but I found a study in 2018 which looked at 12 adults who viewed iPads between 11 o'clock in the evening and 1 o'clock in the morning. They looked at it in 3 different modes: normal mode, night shift less warm, and night shift more warm. And it was noted that all 3 of these modes significantly suppress melatonin. It did note that the night shift suppressed it less than the others, but this wasn't clinically significantly different. Also, there was no data provided on the hours of sleep that this produced and whether it was clinically significant. And therefore, with this small study, I would say that you can't rely on night shift mode to improve your quality of sleep. However, this was performed in adults and wasn't performed in children. And as we've mentioned previously, children appear to be more sensitive to blue light. So it's maybe worth some more research to see whether this would be relevant for them. And the long-term effects of poor sleep are well documented. I've listed some of them here, however, the list is very long. But to mention a few: growth, immunity, cognition, development, weight, and mental health. And whether people are involved in sleep medicine or not, I think it's imperative that we ensure that our paediatric population do have good sleep health. And there are many resources available to us on the internet looking at good sleep hygiene, with one of them listed here at thesleepfoundation.org. I'll then move on to talk about smartphone apps for sleep monitoring. And this is a massive new field with over 500 apps that are available for download. Essentially, they're consumer tracking devices, either via fitness trackers or phone apps, which claim to measure sleep duration. I have a picture here of a download that you would gain from having your app on overnight, which gives you a pictorial of how your sleep has been overnight, with information ranging from your sleep duration, and then some including your sleep quality, your sleep type, and the time and duration you've been asleep. Some include the awakenings, including the frequency and duration of the awakenings, and others have integrated features such as alarm clocks, which aim to wake you up in the optimal stage of sleep so that you feel most alert the next morning. Some of the apps claim to detect snoring, and other apps are integrated with mood, calories, and music, with the aim of improving your overnight sleep and thus your quality of life. The apps can either be worn by fitness trackers, so these are wearable devices such as Fitbit and Fuel Bands, and they're worn as wristbands. They come with complementary apps so that you can download the data and view it as per the previous page. Other applications is just via the download of a smartphone app, and you put the smartphone underneath your mattress, and the display is similar to the previous page. The downside of putting the phone under your mattress is that movements of bed partners, pets, and bedding may interfere with the data that it obtains. So how does the technology work? The data is obtained from inbuilt 3-axis accelerometers to determine activity and estimate sleep parameters. Older devices also have used galvanic skin responses, skin temperature, and heat flux to measure activity levels to determine transitions between periods of sleep and wakefulness. I think it's important to say that the exact mechanisms and algorithms are proprietary, and this is one of the main issues with these apps. Quite a lot of the mechanisms are the same that we use in actigraphy, which is a watch which measures gross motor activity using an accelerometer and real-time clock. But these devices do disclose their mechanisms and have presented validated studies and are used clinically. So are the measures from these tracking devices valid? There aren't a huge number of studies, And they all use generally quite small studies and use different devices, but they do compare them to our gold standard in sleep medicine, which is a PSG. Some of them are with healthy volunteers and some are with suspected or confirmed sleep disorders. But across the board, it's fair to say that they're quite good at detecting sleep, but they're poor at detecting wakefulness. They tend to overestimate sleep time, sleep efficiency, and latency to sleep onset, and they underestimate awake time after falling asleep. They're also universally inaccurate at determining absolute sleep parameters, and there's no correlation with PSG at distinguishing different sleep stages. The same results have been replicated in pediatric population, with a study looking at the Sleep Cycle app, which looked at 25 patients between the ages of 2 and 14 years who were referred for suspected obstructive sleep apnea to a sleep centre. The results of this showed that there was no relationship between the app and the PSG for total sleep time, sleep latency, or sleep efficiency. And this was irrelevant of the apnea-hypopnea index, weight, age, or arousal index on the app accuracy. This study concluded that this is not currently a useful tool for sleep estimation. So are they clinically useful? The answer is sometimes. They're portable, unobtrusive, and they measure people's sleep in their natural environment. They're also accessible, cheap, and quick, especially if you compare to a PSG, which is time-consuming and expensive. And mostly they're used for monitoring overall sleep patterns, such as circadian sleep-wake disorders. You can see in the diagram to the right, a diagram of circadian sleep-wake disorders. The blue bar indicates when the patient is asleep, with the top bar representing a normal sleep phase, with the patient falling asleep at midnight and waking up at 8 a.m. Advanced sleep phase is when someone falls asleep considerably early, in this case 8 p.m. And the third line is delayed sleep phase, when someone falls asleep at 4 a.m. And this can be detected on whole using these applications. They can also be useful in insomnia and can help distinguish between poor sleep hygiene, such as by identifying long daytime naps and late bedtimes. One of the problems is they're less accurate when shorter sleep duration and when the sleep is disturbed, and this limits their use in sleep medicine. And I couldn't find any validated apps to detect obstructive sleep apnea at home in either adults or in the pediatric population. And thirdly, I'm going to talk about smartphones and telehealth. And this is obviously something that we've become much more accustomed to in the last few weeks due to the COVID-19 pandemic. We've been using telehealth far more than we've ever used in our previous careers. And telehealth describes the use of digital information and communication technologies such as computers and mobile devices to access healthcare services locally. Telehealth has been around for a long time, with the earliest recorded telehealth in 1999, when it was specifically used for acute conditions such as telestroke. This was the first app that was launched and allowed patients having a stroke at home access to a neurologist, which increased and improved their access to immediate therapy. However, it's expanded hugely in the last few years, such as video calls, phone calls, and online algorithms, of which the most obvious I could think of was NHS 111, which many people have used in the last week. In pediatric respiratory medicine and sleep medicine, we've also adopted telehealth. From sleep in particular, we use digital downloads to look at NIB data, to review compliance and to adjust parameters from a distance without requiring patients to come to hospitals or clinics. We use video clips in clinic. I think we all find these extremely clinically useful when parents bring in small mobile phone videos of their child sleeping at night, if we're considering they might have suspected OSA, bruxism, or movement disorders, to describe just a few. However, these are really clinically useful, but they've got limited evidence to date. We've also increased our use of telecommunication and are in regular contact with patients via phone and messaging. In respiratory medicine, we have home devices for measuring lung function, which we're increasing again in the last few weeks. We have saturation monitors that we can download the data straight to computers in the hospital. And we use adherence apps. There's also an increase in telecommunication with phones and messaging to our patients. The benefits of telehealth are quite obvious. It promises to be cost effective and time efficient. And it's probably safer for certain patients, especially in current environments where we don't have to bring our high-risk patients to hospital, and has the possibility to improve access to care. On a wider scale, it has the ability to expand and integrate health services. to liaise with centres with greater areas of expertise and knowledge much quicker than previously, and for research facilities to widen resources and data collection. However, there are definitely some barriers to telehealth that I thought I would mention. Some of these would be reimbursement. Clinical barriers are ones that I think are quite pertinent to us. Lots of clinicians lack confidence in clinical judgment over digital interfaces, as it's something that we're much less used to doing and we haven't been trained to do. There are obvious exam limitations. You can miss subtle features when doing a video examination, and some things are just impossible to do at the moment, such as auscultating a chest, listening to heart sounds, or feeling for organomegaly. Peripheral devices may be able to help with this, such as blood pressure monitoring and home lung function, which we can integrate into telehealth, but aren't always available at the moment. And it's possible that we'll require additional training so that we can incorporate this into our practice. Socially, it's harder to engender trust in someone that you don't know, and this is bidirectional with the healthcare provider and with the patient. And it may be that telehealth is something that we use for follow-up visits rather than the initial consultation. And there are also legal concerns over privacy. One of the largest barriers to telehealth would be known as the digital divide. And this describes the differential access to telecommunication technologies. It's known that people who are older, who live in more rural communities and lower incomes, have more chronic conditions. However, this is the population that have less access to technology. And this means that telehealth may have the potential to worsen inequalities, which we're all already aware of at the moment. So what's the validity of telehealth? Essentially, it's quite difficult to draw broad conclusions because the studies looking at telehealth have varied conditions and populations. However, the studies that have been performed do seem to show that interventions appear generally equivalent to inpatient care. In sleep medicine in particular, we've shown that telephone follow-up for post-op OSA was effective in reducing unnecessary outpatient appointments and was shown to be safe. And also a study showed equivalence of home CPAP setup compared to hospital CPAP for adherence levels. In paediatric sleep medicine at the moment, there is limited data to date. However, one of the problems with publishing on telehealth is that it takes a while to get papers into publication. And often by the time that they have been, the interventions are outdated because, as mentioned, technology moves forward extremely fast. So in summary, there's a huge increase in the number of access to mobile phones in all different levels, including mostly in the paediatric population. And there's a vast increase in mobile health and telehealth, particularly over the last few weeks. The way that we've been communicating with our patients in the last few weeks may reshape the way that we perform medicine in the future. And I think that mobile health is something that we have to accept is going to be part of healthcare. I've hopefully discussed some of the side effects of mobile devices that we should be aware of and the limitations in their applications. However, also discussed that they can provide a huge benefit to our patients. As this is a developing field that we're going to be part of, we need to ensure that we develop safe and evidence-based interventions, and we need to consider the knowledge of barriers and the digital divide, particularly when we are integrating these into our common health practice. Whilst doing some research for this, I found this article in the New England Journal of Medicine called Mobile Devices and Health. I haven't managed to cover all of the issues stated in this, but if anyone is interested in this advancing field, I would fully recommend reading this article. It covers in particular many of the ethical implications of mobile health and things that we will have to address in the future. So hopefully this is not all of you at the moment, and many thanks for tuning in so early to listen to this. And I hope everybody stays well. Many thanks.
Thank you very much, Kat. And thank you for the excellent synopsis with it. Can I just remind everyone that there is a Q&A section at the bottom where they can ask the questions there, and I will be able to ask questions on their behalf. While people are thinking, Kat, where do you see in 5 years' time what we will be doing through the technology and health?
I think it's a really interesting question, Atul. I think that what we've done in the last 2 weeks have almost completely reshaped the way that we communicate with our patients. And we've readdressed how frequently people have to come to hospitals. I think that especially also is that some of our population in paediatric respiratory medicine are becoming more healthy with the introduction of new medications. I think much of the clinical health that we do will be through telehealth with patients at home, sending us data, so performing their own home lung function, sending us the information, sending us downloads from their NIV machine, sending us videos, and we'll integrate that in a hospital and communicate with people without actually having to bring them into hospital to anything like the extent that we do at the moment.
Thank you, Kat. So Lisa from Birmingham has asked, thank you for an interesting talk, Kat. These days, our mobile phones are also gives us a weekly report of how much time we are spending on our phones. And the parents often ask how many hours of screen time they should be allowing their child a day. So what would you recommend? Is there a total amount of time in a day that matters, or how much time is spent later at the night?
I think that's a really good question. I think none of us know the complex interplay between mobile phones. I've mentioned the ones that are relevant to sleep medicine, but there's also a huge amount of other effects of mobile phones, such as the radio frequency on brain development and the ability for them to cause mental health issues. As far as I'm aware, nobody has any actual set guidelines as to how the number of hours that someone should spend a day or not spend on a mobile phone. However, with regards to sleep, I think it's very sensible to ensure that nobody uses a mobile phone or a light emitting device within an hour of going to sleep, and instead do calm activities and things that such as reading or playing board games, as this, for the kind of reasons mentioned, has much less psychological stimulation and doesn't have the effect of the light on melatonin suppression. So I think with it's very difficult to put a number on it, but I would definitely reduce the time in the evenings in particular.
Brilliant. Thank you, Kat. Tom Semple from Brompton. Do you think the benefits of technology are going to lead to the new health inequalities? For example, better data from those with more expensive devices?
I do. That was one of the things that was covered in the article, the New England Journal article at the end. It was something I hadn't really considered before. But one of the things it stated was that the lower income populations in America often have an Android phone, and compared to Apple phones, which are owned by the richer population. And actually, if Apple are developing better apps and better algorithms and devices, it's definitely going to lead to healthcare inequalities, even in that small kind of recollection of it. And I think it's something that we have to be really, really aware of if we're taking this forward, as it seems likely, into the next decade with mobile health.
Thank you, Kat. And the last one from Victor. There isn't any significant actigraphy data from children from the UK. Do you think the custom-made commercial devices can help in getting more to reduce the waiting time of a sleep lab appointment?
I think that the apps seem to be reasonable at giving overall sleep duration. So I think if you use them with great caution, bearing in mind the limitations of the studies and of the apps for very particular conditions. So if you're looking at people who do not do sleep diaries, and you're looking specifically for sleep duration, I think that they can be used if you're looking for longitudinal data rather than in one patient, to rule out things like sleep hygiene problems and possibly to consider circadian sleep disorders, but certainly not for things like obstructive sleep apnea or other sleep disorders at the moment.
Brilliant. Thank you very much, Kat, and thank you again.
Thank you.
Thank you. The next, I think we are 10 minutes ahead, but I think I probably